good to see everyone and to be seen. Happy Wednesday, everyone. Thank you all for inviting me to join you for today's session. I'll be presenting on the CHIWOS project and how community involvement since its inception has helped to create a legacy of knowledge mobilization. Uh, First, I'll walk you through the talk a little bit. I'm going to ground the discussion in the values of science and research and how it can be community-centered. Then I'll move on to describing the process of community building that enabled CHIWOS to become the first cohort study to meaningfully engage women living with HIV. And then I'll describe how Black communities are now able to use and access this data to improve their health. And like Amy, I'm also calling in from Treaty 13 territory here in Toronto, but I spent most of my life living in the east end of the city in Scarborough, which is covered by the Williams Treaty signed with multiple Mississaugas and Chippewa bands and cover the lands east of Woodbine Avenue. I recognize the importance of honoring the histories, cultures, and enduring presence of Indigenous people, and I'm committed to continuous learning, building relationships, and ensuring that the spirit of equity and inclusion inform both my own research and my responsibility as a member of these communities. And I just want to express my deep gratitude to everyone who's here today. So, science and research. Oftentimes people get these two concepts confused. Science is a systematic way of understanding the way the world works, and scientific research is how science is done. So the methodology, the design, the questions that we ask to discover new facts, verify ideas, and ultimately to solve problems. And science is shaped by rational evaluation and social forces, right? Um, we know that scientists tell us that it relies on observation and experimentation and evidence, but we also know that opinions and beliefs are also there shaping how we see science. So scientists are people and they're also influenced by societal bias. So the idea of objectivity isn't always true in these cases. So they're imperfect human beings who are influenced by the societies in which they were raised and the social groups in which they live and they work. And this has really meaningful impact on what gets studied, who's involved, and who ultimately the research serves. There has been a history of bias in science. I know that many of you are likely very familiar with the Tuskegee syphilis study, the nutritional research on residential school children here in Canada. And we know that science has inherited these hierarchies of race and gender and class from broader society. So racism, sexism, classism, and other forms of discrimination have shaped how research is done in this country. One of the main ways it's shaped it is through exclusion. Until recently, white men dominated science, and organizations like the National Academy of Sciences in the US originally excluded rather, women and minorities. Here in our federal public sector, in the scientific and professional category, only 3.9% of researchers in the federal government are Black employees. In the States, we know that 2 out of every 3 scientists are white and half are male, and whether or not this truly reflects what we are seeing here in Canada remains to be seen, and that's partially because we're not collecting the necessary race-based data to be able to identify the diversity within our scientific workforce here in Canada. Diversity matters because when you have diverse teams, you get better science, right? It improves creativity and innovation. And so we know that science is not a true meritocracy as it is currently, but fixing science requires systemic change. So hiring practice, mentoring culture, diverse research agendas, and holding people accountable. Scientific progress can take one of 2 forms. It can be progress at the expense of communities, which we've seen, and community-centered scientific progress. The difference between the two is that when it's at the community's expense, innovation and discovery advances are done without regard to the well-being, consent, or rights of the people affected. And this can often reflect kind of top-down approaches in some cases, ethical violations, environmental harm, displacement of people from their lands and their property, inequitable distribution of the benefits of the research and the populations involved, as well as stigmatizations of the population being studied. They prioritize profit and prestige and progress over people. And this can have long-term circumstances for exploited groups. A model that's centered on community places community at the heart of research and development. So in contrast, it ensures that communities benefit from, have agency, and are protected through the research that they participate in. So it's participatory in its nature. Oftentimes, Indigenous knowledge and Indigenous peoples from Turtle Island, Africa, Asia, Australia, Europe are included in studies within their communities. Ethical technology development and the development of medicines and prevention technologies also in these cases have built-in safeguards, have an inclusive design, or a community review process to reduce bias and harm. So in contrast, it focuses on really informed consent, co-leadership, has a mutual and long-term benefit to participants in their communities, as well as strong ethical oversight and transparency, and values local knowledge and sovereignty. So this is, I just want to actually thank Marvelous Machenji and Wangari Thoreau for sharing this slide with me. Community resilience over the years has helped shape policies, healthcare, and research on a global scale. And so when we talk about community resilience, we're talking about the meaningful involvement of people living with HIV or MIPA, and it has a rich history rooted in advocacy and activism. So in 1983, the Denver Principles were developed with a manifesto that was issued by PHAs at a conference. And then in 94, the Paris AIDS Summit declared JIPA the greater involvement of people living with HIV, where 42 countries endorsed JIPA. So that progressed to the development of MIPA, which was a core principle of UNAIDS and called for incorporation of meaningful engagement at the country level of all UNAIDS countries. And then in 2006, there was a shift towards a call for involvement in community-based research, involving research associates, peers, and advisors as data collectors. And then currently in 2025, not just here in Canada, but more prominently in the US, we're seeing a retreat from equity principles and diversity and equity and inclusion through racist and exclusionary policies that we're seeing emerge from the US, which has important impacts on Canadian research. So a lot of progress, but it also feels like we're slipping back a little bit. So I just wanted to also mention that these troubling developments are likely to impact work that's happening currently here as well. And when we talk about research centered on community, this is what it actually looks like. So this is where I'm going to talk a little bit about how CHIWOS was one of the forerunners in this space around community-based participatory research, specifically with women living with HIV in Canada. Many people recognize that women living with HIV did not reap any of the benefits from JIPA-MIPA from 1983 well into the mid 2000s. And in late 2000 and mid 2000s, 2006 to 2008, through a partnership with Dr. Muna Aden at Women's College Hospital, who had received a grant to do the women-centered CBR project titled Involving Ontario HIV Positive Women and Their Providers in Determining Their Research Needs and Priorities. Community-based organizations such as Women's Health worked with Dr. Mona Lutfi to develop this partnership. And this project really laid the foundation for involvement of women living with HIV as partners in research in Ontario. So this study is actually the forerunner of the CHIWOS study, the Women's WCBR project. And so for this project, we recruited and trained 12 peer research associates, the majority of whom are Black women living with HIV, who supported implementation of the study. They facilitated focus groups, and they also did a quantitative survey with about 170 participants. The analysis that was done on this data was used to inform and form the framework for the Canadian HIV Women's Sexual and Reproductive Health Cohort Study, or CHIWOS. And it really focused on intersectional stigma and the outcomes of Black women living with HIV. And then CHIWOS was expanded to include broader issues that from the topics that emerged from the WCBR project, and the aim of the CHIWOS study became to assess the barriers and facilitators of women-specific HIV/AIDS service use and the impact of those barriers and facilitators on the sexual, reproductive, mental, and other health outcomes of women living with HIV across Canada. We moved on from just Ontario and just the topic of stigma to address these large overarching barriers to health. And so these were some of the grounding frameworks that emerged from the WCBR study that helped inform CHIWOS and was later highlighted as the frameworks for the CHIWOS study. And they included OCAP, critical feminism, JIPA, MIWA, CBR, intersectionality, social justice, and many other important grounding frameworks. In terms of engagement, approximately 30% of all PRAs that were later hired for the broad national CHIWOS study were ACB Black women, the majority of whom were located in Ontario. PRAs were women who were living with HIV, and they really facilitated and operationalized JIPA, MIPA, and MIWA. PRAs played a central role in data collection, so they were working directly with participants, collecting data, documenting the experiences of women living with HIV. They helped also bridge the gap between researchers and participants by providing a different lens on what they were hearing from participants. They also fostered trusting relationships with the researchers and really helped to create what we now call safe spaces. At the time, this wasn't a concept that was as well defined as it is now, but this is one of the first instances of the creation of this kind of safe space in the research sector. And also, PRAs played a really crucial role in promoting inclusive and authentic research and ensuring that the environment was a place where people could share their experiences. And so a lot of great outcomes came out of women's participation in CHIWOS. Communities felt more empowered. There was sustained participation and inclusiveness and responsiveness to the needs of ACB women living with HIV. It felt like for the first time people were being heard. And so people were able to develop their capacity for advocacy and outreach and connecting research and community. Peers also helped provide a more comprehensive understanding of how race, gender, and HIV intersect differently for different populations in terms of health outcomes and service access. The inclusivity of the peer model led to more than 400 ACB or Black women participating in CHIWOS, so that was quite large for a study at that time. And ACB women and their CHIWOS research partners are really pioneers in equity research, health equity research here in Canada. So a huge impact. So that brings us to the now that the CHIWOS study is finished and there have been 3 successful waves of data collection, as well as a number of presentations, papers, and quite a large library that could be accessed on the CHIWOS website. We have been working with the Black Health Equity Lab and the ACB Subhub, who some members of the Subhub are present today, to really look at how can this data be used more broadly and more effectively by community. And so CHIWOS, we were calling it the CHIWOS ACB Data Access Initiative, and we're really aiming to see research more holistically. So if we look at research as an intervention, it enables us as Black people to develop our own analyses frameworks, so look at things a little bit differently. We're also able to translate this research into political action. So using the great work of CHIWOS to be able to highlight issues and then take those issues to the tables where a difference can be facilitated or made. And then it also enables us to create partnerships that are equitable with communities and academic institutions. And when we think of research as an intervention, we're really thinking about building a foundation of research for Black communities. And so this particular data from the CHIWOS study is playing an integral role in how we are able to engage with that data from the lens of EGAP. And EGAP stands for Engagement, Governance, Access, and Protection. And the Black Health Equity Lab and the ACB Sub-Hub aims to operationalize these principles in order to eliminate the further pathologizing of ACB communities, in order to provide a space where ACB women living with HIV feel comfortable expressing themselves and are supported to building their leadership skills, to participate in research, establishing mentorship opportunities for ACB women living with HIV and newly involved in HIV/AIDS work, and recognizing ACB women's lives within a transnational space and a hybrid of cultures and practices, and understanding how to use the appropriate research and methodologies to capture these issues. So when we say we're operationalizing EGAP, what we're saying is we're engaging with Black communities. We've formed a governance structure that includes the ACB Sub-Hub and members of the ACB Sub-Hub to oversee the work that we are doing. We're able to access collective data. So CHIWOS study is collective data. ACB women were involved in the production, collection, and the research teams that developed this research. And now we're able to work with the CHIWOS study team to access this collective data, and protection of individual rights and safeguarding. So taking the necessary measures to ensure that the data remains safely and secure. So what have we done? To summarize, the ACB Women's CHIWOS data was transferred rather by the CHIWOS study team, Dr. Mona Lutfi and her team, to the Black Health Equity Lab, which is led by Dr. Notisha Massaquoi, who is part of the ACB Sub-Hub, along with Wangari Thoreau. And so what we did was we formed a National Program Expert Steering Committee. And what we did was they worked directly with the ACB Sub-Hub. So we brought these two groups together under one umbrella under the ACB Sub-Hub. And we used some qualitative techniques to kind of focus questions around priorities to help us guide the development of content for this project. And so we met monthly last year, and we had two working groups, a community mobilization working group and a data working group. So the data working group worked on this project, and we were able to develop a culturally responsive governance structure informed by lived experience and protocols for how people can ethically access the data and use it. And we shared that with community members at an event last year was it November? I can't recall, but we had our knowledge mobilization event for the ACB Sub-Hub at the PWA here in Toronto, where we presented the process and let people know that this is data that community members are able to access. And so the data working group of the ACB Sub-Hub came up with three main areas that were really important, that they felt were really important around looking at the CHIWOS data. The first was healthcare access and utilization, chronic health conditions and comorbidities, and HIV care rounded out the top three. So while people can access any data research question, they can access data to answer any research question. These were the three kind of broad question categories that was of interest to the data working group. And so we presented some of that initial data that on the subpopulation of Black women in CHIWOS at the community event and got some feedback, and many others have reached out to us hoping to be able to access the data as well. And so we looked at some of the characteristics to ground our discussion in the lived realities of African, Caribbean, and Black communities in Canada by looking at some of their key characteristics. The average age of participants in CHIWOS who were Black was 46 years of age, with ages ranging from 19 to 77. On average, participants were diagnosed at the age of 31, and nearly half have been living with HIV for over 14 years. Another 42% have lived with HIV between 6 and 14 years, and only about 8% were more recently diagnosed. And these numbers underscore that this is a community with deep long-term lived experience of managing HIV, and yet they continue to face structural barriers in care access. In terms of sexual orientation, the majority of Black women who participated in the study reported that they were heterosexual at 94.4%. In terms of legal status in Canada, just over 62% of participants identified as Canadian citizens. And while this might suggest access to full legal rights in healthcare, we know that citizenship doesn't shield people from racialized stigma or systemic barriers in care. A significant portion were permanent residents, so about 31%. These individuals may face additional barriers accessing services depending on the province and length of time in Canada. Almost 7% were either refugees or fell into other immigration categories, and this group may experience higher vulnerability, facing intersectional challenges like temporary status stress and limited access to public health systems. In terms of education, which is a powerful social determinant of health that shapes not only employment and income, but also shapes health outcomes, not surprisingly, we found that nearly 60% of participants had an education beyond high school. So were either college, university, or other post-secondary education trained. Just over 17% had completed high school as their highest level of education, and about 1 in 5 had not completed high school. And to round up some of the social characteristics before we move on to the key areas that community members highlighted were key to data that they'd like to access. Less than half of the participants were employed at the time of the study. About 47% were employed, 52% were not employed. And this matters because employment is more than income. It's often tied to social support, mental health, and access to extended health benefits. Financial constraints were also clearly visible. Over 41% of participants had household incomes less than $20,000 annually. Another 35% earned between 20K and 40K, and just 21% reported incomes above 40,000. And this highlights the economic precarity many are navigating, especially when layered with the costs of healthcare, child rearing, and housing. Interestingly, despite income barriers, 98.6% reported having stable housing. So this is a positive finding, likely due to housing supports and family networks. A number of children were about 41% had more than 3 children. Another 21% had 2, and 18% had 1 child. Just under 20% had no children. So the majority of participants were parenting while managing their HIV and navigating structural inequities. And this has real implications for care models and support systems. Speaking of support systems, the lowest support, so this is in a unique kind of take because we're comparing the Black women in the study to other groups of racialized and non-racialized women. And in contrast to other participants, Black participants report the lowest perceived social support. And this is concerning because it points to intersecting barriers of racism, migration-related isolation, and in some cases, mistrust of community institutions. So it underscores the need for targeted culturally relevant support systems to build trust and community connections. So one of the areas that community members highlighted as requiring some focus included HIV care and treatment. And so when we looked at that, we found that an overwhelming 95.8% of participants reported being on antiretroviral therapy, which shows that the vast majority of Black women in this study are engaged in care and adhering to treatment regimens, and also reflects the effectiveness of community outreach, treatment programs, and possibly peer navigation supports. And among those who reported recent viral load results, 92.7% were undetectable. So this is also significant, as you know, with U equals U, and the undetectable equals untransmissible. In terms of adherence to antiretroviral therapy, 23.8% reported adherence below 95%, while the majority are maintaining strong adherence, nearly one quarter, so the 23.8 fall below optimal levels. The other area that community members highlighted as a focal point was access to healthcare. And so the good news here is that in terms of time to get to medical appointments, nearly 75% of women were able to reach their care provider in under an hour. So the first two categories, less than 30 minutes and less than 60 minutes. So 20% traveled less than 30 minutes, 49.3 traveled just under an hour. So this is important because shorter travel times reduce the burden of accessing care and increasing likelihood of regular follow-up. However, 25.4% reported needing between an hour and 3 hours to get to their provider. That's just one in one direction, which is a significant chunk of time, especially for people who are balancing work, caregiving, or other healthcare challenges. When asked about having a family doctor, 68.4% of women reported having one, which is encouraging and suggests that the women in the study had a consistent point of contact in the healthcare system. Nearly 1 in 3, or 31.6%, did not have a family doctor, and this reflects systemic barriers, including shorter provider shortages, lack of culturally safe care, language barriers, or even past experiences of discrimination. Cost to getting to your HIV care. So not just the time cost, but also the financial cost. The majority, 62.2%, spent less than $25 per trip. Even though that seems relatively manageable, when you combine it with the frequency of appointments and a low income, it can still be a burden. Over a quarter of participants, more like a third of participants, around 21.7%, spent between $25 and $100. And this is pretty steep, especially for people with multiple appointments with different providers or services. So that's 1 out of 5 people, so 21.7 people. And we also wanted to look at chronic health and comorbidity, specifically around ever being diagnosed with high blood pressure. Only 18% reported ever being diagnosed with high blood pressure. This initially might seem like a relatively low figure, especially when you consider the trends among Black communities in Canada and across North America, where hypertension tends to be more prevalent. It's also possible that this may reflect some underdiagnosis, particularly with those who don't have consistent primary care or who don't undergo routine screening or have culturally competent care providers. Body mass index, a fifth of participants, 21.7%, were in the normal range for their body mass index, but about a third, 32.1%, were categorized as overweight. This similarly, about 34.4% were classified as obese. So over 60% of the ACV women in this sample were considered overweight or obese, which can have challenges related to metabolic syndrome, diabetes, and other health challenges. So this might actually indicate that the hypertension might be slightly underreported, actually. Just over 51.8% of Black women in the study reported that they had no diagnosed mental health condition, but a substantial number of women said that they were diagnosed. So 48.2% of participants said that they were diagnosed. Nearly half of the women living with HIV had the dual burden of HIV and a mental health condition. So this really underscores the need for integrated models of care that address mental health diagnosis along with HIV care. And it also speaks to the importance of trauma-informed and culturally grounded mental health services. This slide presents reported HPV vaccination status among participants, which is a critical issue because the human papilloma virus, HPV, is the leading cause of cervical cancer. And about 68.7%, more than 2/3 of participants reported that they have not received the HPV vaccine. And it could be reflective of barriers such as cost, lack of targeted outreach to racialized women, gaps in primary care engagement, or misinformation about who the vaccine is for. Only 16.3% were fully vaccinated. Okay, so I'm going to pause here just to kind of highlight what we've talked about so far. This work really highlights the transformative potential of research collaboration to increase access to data using EGAP principles. Community members are now able to work directly with the ACB sub-hub to look at any research questions in the CHIWOS study that they're curious about. Service providers can also work with the ACB sub-hub to identify questions important to their work. And students and trainees and other researchers are also able to look at the CHIWOS data set to help inform their scholarship. And so these are really great. This is a really great continuation of the life and legacy of the CHIWOS study. And the next steps for the ACB sub-hub and the National Expert Steering Committee is to promote the Data Access Initiative, to recruit, orient, and launch a review committee to review applications for the data, and to support applicants who want to look at this data to support their knowledge in their communities. So I'd also like to acknowledge the National Expert Steering Committee, whose names are listed here, as well as members of the ACB sub-hub, especially those that helped develop these protocols for the data working group, chaired by Shamara Baida-Bonzo. And so to wrap up, I'd just like to say that data can affirm lived experiences that are often ignored or erased. And when individuals see their realities reflected in research, not as an afterthought, but as a central focus, it sends a message that they matter and that their story is valid. And so this is especially healing for communities historically over-surveilled but under-supported. And data, when collected ethically, like in the CHIWOS study, and presented respectfully, can help interrupt erasure. So data doesn't just describe the world, it helps to reshape it. When equity-focused findings from policies, funding, and service delivery are supported and enabled, data acts as an intervention in itself. So thank you all, and you can stay connected by reaching out to Dr. Notisha Massaquoi or going to the Black Health Equity Lab website. And I think, did I have the slide with, yes. And if you'd like to access the data or know community members or researchers who would, you can contact us using the QR code on this slide.